Sarah Morrow at the Consortium of MS Centers annual meeting, and yesterday at the meeting, Dr. Morrow was one of the presenters and a co-collaborator in a consensus statement on managing progression in MS. Thanks for being here today.
Thank you so much for inviting me.
So, how did this project come about? I guess we can start at the beginning.
Absolutely. So I'm the chair of the consensus committee for the Consortium of MS Centers. So part of my job as part of the CMSC is to bring these consensus statements to life. So sometimes they're brought to us by other people, sometimes they're brought to us internally. This one was actually brought to us by a pharmaceutical company who wanted us to address progression in MS, but not from a DMT or disease-modifying therapy point of view. But they thought it would be really important for us as care practitioners for people with MS to talk about progression and how that should be managed, because we are now dealing with that more than we are dealing with the inflammatory part of the disease because of the effective disease-modifying therapies we have. So this one was spearheaded by funding that we received, but it is very hands-off. So it's very much driven by us as clinicians as to what we want to talk about and how we want to do it.
So yesterday's presentation was about this process and about the statement. I imagine the publication of that statement is happening in the not too distant future?
Hopefully. We have been working on this for about 8 months now. What we've encountered as we've been looking at the evidence, because we wanted to look at not just pharmaceutical interventions for multiple sclerosis or progressive multiple sclerosis, we wanted to look at non-pharmaceutical interventions. So things like dietary supplements, exercise, lifestyle management, other things like that. It's taken us a lot longer to coalesce all the data because the evidence for those types of intervention are not as rigorous as you might see for pharmaceutical or drug interventions where you have traditional phase 3 trials. A lot of these are observational trials, or they are trials where it's a bit looser in terms of how they're evaluated, the outcomes, or smaller numbers. So it's taken us a lot longer to put the data together and decide how to present it. We'd really, at the beginning, thought we would make it much more rigorous, like a Delphi consensus. But we realized with the evidence we had, we can't do that. So instead, we're hoping to make it a recommendations paper with recommendations in terms of how strong is the evidence, knowing that sometimes we will just not have strong evidence, and that's really the best we can do. And then taking it a step further and saying, what are we missing and how can we make this a call to action in terms of trying to improve the treatment options for people with progressive MS?
And I guess that's one of the things I wanted to talk about was this concept of progressive MS, so much so that one of your co-collaborators, Dr. Greenberg, yesterday made the statement and I think showed a slide that said progression is a phenotype.
Yes, so progression is really, when you think of phenotype, it's just a description, right? Which makes it difficult because we also use the word progression as a diagnosis, right? So we say that there's relapsing MS, there's progressive MS, which is a label or a diagnosis. Whereas truly, progression is just that, a phenotype. It's a description of what is happening. So you can have any type of MS and still have some progression. It describes what you're experiencing, what the patient with MS is experiencing, or what we might be finding. Or finding on exam or finding during the interview. So it makes it difficult when explaining that to people living with MS, that you can still have progression, you can still have that phenotype where you're worsening over time, even though you don't have a definition or a diagnosis of progressive MS. And that dichotomy sometimes makes it difficult to treat it, which is one of the reasons we want to do this paper, because it's not just about treating that label of progressive MS, but it's treating those symptoms that are causing worsening function of our patients over time.
So function is an important word. It seemed to me in listening to what was being said that a lot of this has to do with symptom management and symptom treatment rather than managing the disease activity, right? And as I sat there, I kind of wondered, in an era that's being defined by high efficacy DMTs as a first line therapy, at a time when progression independent of relapse activity is something widely recognized and hopefully soon to be better understood, right? Does progressive still hold any kind of a meaning? If we accept the fact that even in the absence of inflammatory activity, neurodegeneration is taking place at some pace pretty constantly throughout the disease course. On the one hand, everybody is progressing.
Absolutely. I think that's part of what we were struggling with, is that there's so many parts to your question that I want to try and address. But I think the new diagnostic criteria when it came out says MS is one disease. There's MS. And then some people might show more relapsing biology, some people might show more progressive biology, some might show a bit of both. And I think that's a huge step forward. And part of that is because, as you said, these high efficacy therapies have pretty much eliminated inflammatory activity, which we all thought was the holy grail. We all thought we're going to do that and people are not going to progress with their MS. And now we realize that they are. And it's focusing us as researchers to say, why is this happening? Because if they're not having any inflammatory activity, which we thought was what was driving progression, something else is happening, which, as you said, is likely this neurodegeneration that's happening in parallel with the inflammatory activity. We're just really good at suppressing inflammatory activity. We haven't quite identified what is the cause of the neurodegeneration. So talking about what you first said with treating symptoms versus the underlying process, I think it's partly because we don't know. We actually don't fully understand the underlying process that leads to neurodegeneration. And sometimes treating the symptoms will help us learn that. So in some ways, treating relapses, which was a symptom of MS, helped us learn what a huge part of the underlying mechanism of the disease was inflammation. Even though that wasn't necessarily the goal when these disease-modifying therapies came out. It was meant to just stop relapses and then to stop MRI activity. So although we talk a lot about treating symptoms, sometimes we don't know if treating that symptoms actually might be treating the underlying biology. Are we treating a secondary consequence of the disease, or are we actually getting to the heart of what might be causing the progression? In some ways, does it matter to the patient sitting in front of me? Probably not. They just want to feel better. They just want to stop feeling worse or stop getting worse. But from a researcher point of view, that's really important, because we're never going to advance the science of progressive MS unless we try to dig down and say what is actually a secondary consequence of the disease process and what's actually being driven by the disease itself.
We're at an interesting point in time when it comes to what experts know about MS and what they're still learning about MS. And part of being at that point in time is the current course descriptors: relapsing, remitting, secondary progressive, primary progressive. They don't seem to be fit for purpose any longer. As I think you alluded to, a patient comes in and their neurologist says, well, your MRI, it hasn't changed, your MS is stable, and they're sitting there knowing that, I don't feel as good as I did last year. Maybe I've recognized my gait is a little off. Maybe I have some memory issues that I haven't had before. They know something has changed, right, in their overall well-being. So there's also an effort underway to develop new course descriptors that are going to be more focused on the biological mechanisms driving the disease, as opposed to, naming conventions that made a lot of sense in 1993 when they were first adopted, right? Obviously, you and your colleagues have learned a lot about MS since 1993. I'm curious, given the timing of all this, do you see putting a label, progressive MS, as well, what this statement is about, is that clarifying or adding to the confusion of what this is right now?
Both. It is both adding to the confusion, but hopefully also clarifying in that it's adding to the confusion in that, as we said, progression is both a diagnosis and a descriptor. I don't think we're ever going to get away, at least in the near future, from those descriptors because the payers require them. So you have to say you have progressive MS primary progressive MS, for example, or relapsing MS in order to get coverage for certain drugs. So we're not going to get away from that in the short term, but I think in the long term we might. It does add to the confusion in that so many people still read things that are on the internet where they use those descriptors. Even great resources like MS Canada or NMSS, they still have those descriptors on there. And so patients are coming to us saying, like, do I have relapsing MS? Do I have progressive MS? Do I have the bad kind or the good kind? Which adds to the confusion. But on the flip side, I feel like in some ways we're taking away some of the confusion as to what patients are experiencing. Because I think what you said earlier, where, physicians were saying or clinicians were saying, your MRI looks fine, you haven't any relapses, you're fine. And the patient saying, I'm not. In some ways, we're now validating what they were saying because they were right all along. Of course, the patient was right. They knew what they were experiencing, right? So we are now validating and saying, yes, what you're feeling is real. It is worsening of your disease in some way. Why is that worsening happening? Is it because you're aging, and aging can increase disability just without MS, and then you put the two together? Is it because of some other comorbidity, because you've developed type 2 diabetes or heart disease or osteoarthritis? Is it due to the underlying MS pathology, or perhaps a combination of the two? What they're noticing is real, and that progression is real, and saying that it's occurring allows us to treat it and allows the patients to then talk to us about it so that we can treat it.
So I think you've already started to answer my final question, and which is great. And that is, most of the people who are going to hear this conversation are people who are living with MS. They want to know what's in it for them. What is the patient benefit of this consensus statement?
Well, on top of trying to make it comprehensive for clinicians. So a neurologist treating MS doesn't just treat relapses, as we know. They treat bladder, bowel, spasticity, gait immobility, pain, so many other things, incoordination. So it's hard to be an expert in everything, right? So hopefully putting all this together means that in some ways it'll be a one-stop shop for clinicians to be able to say, my patient's having this, what is the best evidence for me to help them, rather than having to pull a bunch of different data together. So hopefully we're going to allow people who perhaps don't live in the MS world all the time. So many of us here are MS experts, right? We work in tertiary care centers where we work in MS clinics, and that's all we do. But there's a lot of clinicians out there who don't, right? So giving them the tools that they can better treat their patients is important. One of the things about the CMSC, which I really like, which is one of the reasons I like to be a part of it, is that we also try to do patient-facing tools. So the goal with this is not just to do a consensus statement for clinicians, but to hopefully also get some tools together for people living with MS to give them the language so it's hopefully less confusing, is what's progression versus primary progressive MS, that kind of thing. On top of that, I think the benefit for the patients is that it will give both clinicians and the patients that language to talk about it. You mentioned cognition. That is one where there was a huge disconnect for a long time between patients and clinicians, where clinicians say MS doesn't affect cognition, and patients were saying, but I'm not doing as well at my job, or I'm not remembering things. And it took a long time for us to get that language to allow clinicians and patients to talk about it. So hopefully this will help bridge that gap faster so that clinicians can help patients with better skills and easier access to knowledge, and patients will have that language to bring to their clinicians and say, I'm noticing this, and I think this is due to my MS.
Well, Dr. Sarah Morrow,